hypertensive crisis, hypertensive emergency, and hypertensive urgency. Hypertensive crisis is when blood pressure rises to a critical level that can endanger organs. In this video, we will break it down step by step, how to recognize and diagnose it, and how to tell the difference between emergency and an urgency, and finally, how each should be treated. Hypertensive crisis is defined as a sudden, severe increase in the blood pressure reading of more than 180 for the systolic blood pressure, over 180 for the diastolic blood pressure. Hypertensive crisis is considered as a medical emergency. Without immediate intervention, severe cases can be fatal. It can lead to heart attack, stroke, or other life-threatening health condition. We are dividing hypertensive crisis into hypertensive emergency and hypertensive urgency. Hypertensive emergency with E, it means severe elevation in the blood pressure more than 180 for systolic and 120 for diastolic with the evidence of acute target end organ damage. So emergency with E, so we have end organ damage. The next is hypertensive urgency, is severe elevation but without any evidence of acute target end organ damage. Let's take a closer look how to differentiate between hypertensive emergency and hypertensive urgency based on the associated symptom. So, hypertensive emergency present with signs and symptoms of hypertension induced end organ damage, as we said previously. The end organ damage can involve neurological symptom, retinopathy, cardiac, renal, eclampsia or preeclampsia. So neurosymptom that could be present, focal neurological deficit, stroke, encephalopathy, acute ischemic stroke, intracerebral hemorrhage, headache, confusion or seizures. Retinopathy can be presented with papilledema on fundoscopical examination or vision changes. Cardiac features can be from chest pain due to myocardial infarction or severe dyspnea due to acute heart failure, the left ventricular heart failure, aortic dissection, or acute pulmonary edema. Renal symptom can be oliguria or acute kidney injury, eclampsia or pre-eclampsia if it's happened during pregnancy. For hypertensive urgency, as we said, it's usually asymptomatic. Some patients may experience symptoms like headache, anxiety, epistaxis, dizziness, lightheadedness, but no any evidence of end organ damage, as we discussed in the hypertensive emergency. Okay. How to diagnose hypertensive crisis? First, you have to confirm blood pressure measurement by using properly sized cuff, measure at both arms, and repeat readings. Then you have to take a detailed history and do physical examination. So ask about medication compliance, drug uses such as cocaine or monoamine oxidase inhibitors drug, symptoms of the headache, chest pain, neuroscience, and also try to examine for fundoscopic changes indicating retinopathy, any sign of heart failure, any signs of neurological deficit, or abdominal fluid. More specifically, to evaluate each organ based on the presence of the symptom, if we have symptoms suggestive of neural involvement, like headache, any confusion, weaknesses, seizure, or any symptom of stroke, like sensory changes or any motor changes, we have to do CT brain. If the symptom going to the cardiac, we do ECG and troponin. Renal, we have to do renal function involving the creatinine and urine analysis. For eye, we have to do fundoscopy. For the chest, if there is suspicions of the end of pulmonary edema or aortic dissection, we have to do the chest x-ray. Other lab tests like complete blood count, liver function test, PMP for cardiac involvement, and toxology screen. Pathophysiology of hypertensive crisis is mainly due to abrupt rise in blood pressure, which lead to the endothelial damage here, the blood vessels with the endothelial lining. So high blood pressure will lead to injure this endothelial lining. So in injuring this endothelial lining will lead to vasoconstriction. This vasoconstriction will limiting the blood pressure, leading to ischemia. Ischemia will finally lead us to inflammatory activation. This will end in the target or in target organ damage due to ischemic changes. Treatment. We're gonna divide the treatment into treatment of hypertensive urgency and the treatment of the hypertensive emergency. So from the start, it's important to differentiate between both because they are different treatment protocols. For hypertensive urgency, as we discussed before, the treatment here is mainly by oral medical therapy like nifedipine, captopril, or labetalol, and the aim here is to decrease the blood pressure over days and not hours, and you have to closely follow up the patient in the outpatient setting. Okay, here is the treatment of the hypertensive emergency. As we said, hypertensive emergency, so there is meaning of involvement of end organ damage. So in such case, it requires immediate intravenous or parenteral therapy, usually in the ICU setting, and the aim is to gradually lowering the blood pressure to a safer range, not to exceeding or not more than 20 or 25% of MAP or mean arterial blood pressure in the first hour, then followed by further reduction over the next few hours. For example, if the initial blood pressure was 180 over 110 or 20, the target will be approximately 140 over 90. It's important to avoid rapid overcorrection because it can lead to ischemia. Okay. Optimal medical therapy IV with IV antihypertensive is dependent upon the specific organ. So we have many different types of IV antihypertensive medication, but we have the preferred agent based on the involved organ. Here in this table, we have the involved organ with the preferred medical agent. So, in general, in the neuro or CNS involvement such as hypertensive encephalopathy, acute intracerebral hemorrhage, or subarachnoid hemorrhage, the preferred medical agent is labetalol, nicardipine, ismolol are the three preferred agents. In cardiac cases, aortic dissection, the preferred is labetalol, nicardipine, nitroprusside with beta blocker, ismolol, and morphine sulfate. In the acute coronary syndrome, the beta blocker and nitroglycerin is the preferred agent. In acute heart failure, IV nitroglycerin or sublingual nitroglycerin and IV enalaprilat. In case of preeclampsia and eclampsia, the hydralazine, labetalol, and nicardipine is the preferred medical treatment. Okay, this brings us to the end of today's topic. Thank you for your attention and hope this was